Hi, my name is Dr. Liz Boaden. I'm a speech and language therapist. I qualified a very long time ago, about 30 years ago, and I have been practicing speech and language therapy within the NHS for all of that time. I have specialised in swallowing difficulties, which is dysphagia, and I'm currently researching different aspects of swallowing difficulty.
Hello, my name is Veronica. By profession, I'm a speech and language therapist, and now I work as a digital health clinical lead, which is a big variation from how I trained initially. But I'm very happy in my job helping people to use technology to evolve new ways to deliver healthcare.
Okay, so it was because I worked in the NHS for such a long time. I got very frustrated actually that people were waiting to have their swallow assessed, and all the time that they were waiting they were getting worse, and they were getting chest infections, and they were getting admitted to hospital, and I felt as if I needed to do something different.
Yeah.
I felt as if I couldn't continue to see one person at a time and just make a difference in that one person when there were a whole lot of other people waiting on that list.
Yeah.
So I had to look at it differently. I had to take a step back and take a more strategic view of what was going on in the hospitals and in the community and do something about it.
Well,
and
you got yourself a PhD as well doing it, didn't you? So it's been hard work.
It's been hard work, but I think we've got something really valuable now.
Yes, I agree. And, you know, that's where we came in with the tele-swallowing concept, wasn't it? That we knew we had skills, we knew that technology was developing, and we knew really that we had to sort of put ourselves at the front line and say, we are working for the NHS at the moment. How can we grow the NHS? How can we influence our own profession? So I remember one day I was at my desk at my hospital, and there was some funding, which is lovely. Funding in the NHS, yeah. And I just thought, well, can we do something about eating and drinking problems using technology? And I'm going to see if someone will give us some money for that. And that's what happened first of all. I got some money, and I had the idea that we can reach out to our population, our citizens, and do it with video conferencing. Hadn't done it before, wasn't even on WhatsApp. I don't think that was developed then.
No.
And so when we set up that trial, then of course we needed someone with research background. Now, little did I know that you were there having the same sort of ideas.
Yeah.
So we had a meeting of minds, didn't we? And immediately
absolutely.
we got on.
Absolutely. So then I came along to set up the pilot, because we couldn't just introduce something that was totally new within the NHS without having some data, some evidence to back up what we were doing. So I think that's when we came up with a feasibility study where we were looking at people in the community having swallowing difficulties, and that came from a range of disorders. So it was stroke, and it was head injury, and it was degenerative diseases, just your general population that you would see in those nursing homes.
We wanted to test it, and we did test it initially. We connected to 3 nursing homes, then 5, and what we did, my NHS trust was really good, and it invested some time and energy into putting some devices, so an iPad actually, in these 3 nursing homes. We had some software that would enable video conferencing to happen, and so we were good to go, but we had to put some training in those care homes. So the nurses who were going to link up with the speech and language therapists had to know what they were doing. And that's really crucial to get that, the confidence, I think, in the staff. And so we had our pilots set up to go, and we went live, didn't we?
Indeed. So in the pilot, that was really important for me. So we had to know that actually we got the diagnostic accuracy right. That it wasn't a poorer service than what they would get if
not
they were
interested in a second-class service.
No.
You had to get it right.
Why would you be? So we went in and we did the training, and we sent out speech and language therapists, and they were of the same grade and had the same practice and worked with each other for years. And some people, we were randomised the visits, so some people went out and did a remote assessment, and some people went out and did a face-to-face assessment. They were blinded to each other's results. The intervention that was different was the approach, was the mode of delivery. What we were actually doing, the assessment was exactly the same.
Yes.
We were just using other people to be our eyes and our hands on the patient at that time.
And I remember doing the trial, and so, I mean, it really was a way to get my clinical expertise over just in a slightly different way. And I remember doing these assessments, and so I'd press the button and I'd link into the care home, and suddenly there was Mabel sitting there, bless her, because she must have thought the television was starting to talk.
And so it was you, unfortunately,
it was
at the other end.
It was me, and we had a really good rapport. So I would say, Mabel, look, it's your speech therapist, you know who I am.
Yeah.
And what I'd like to do is try and ensure that your eating and drinking is safe, so you can have that piece of cake and you won't be spluttering it and coughing. And we collected the data, which is so important. And then we looked and analysed the data, didn't we?
Yeah, and we found out that people were giving the same instructions, the same modifications, the same advice, the same therapeutic strategies, whether they were doing the assessment remotely or whether they were doing it face to face.
So we knew we were onto something.
Yeah.
And so we did it all again. So
on a much larger scale.
Yes. So, you know, with a new intervention, so this is a new digital clinical tool. And we wanted something for our profession to make sure that they would use it, but also basically it's for our patients.
Yeah.
And so we did it all again, and we made sure that the technology worked slicker, so we refined what we were doing. We had about 7 nursing homes at this point, and again we collected the data. So what did the data show us? Quite some, well, really surprising data. So first of all, I think the expertise in the care and nursing homes increased.
Yeah.
So
their
that
knowledge.
was yeah.
They felt more confident when they were doing the assessment, and they felt more engaged, I think, with the speech and language therapist.
Yes.
And the speech and language therapist didn't have that situation where they went in and delivered training and walked away again and just fingers crossed that everything worked and they remembered what they were meant to be doing. Yeah. Because actually you can just check on the nurse that the finger placement is correct when they're palpating the throat. You can just check the person is sat in the right position.
That's right.
And so you can actually maintain the nurse's capacity and their capability whilst you're on the video.
And do you know, looking back on it now, it really makes me proud to think that we've developed a solution that is actually reducing risk.
Yes.
Because when you've got all these patients and you can't get out to see them all, what you do, you make a phone call. And that's fine, you can give expertise, but you can't see the patient.
No.
Now, I call the tele-swallowing approach a telephone with eyes, so we get an eyes on. And I think that is very important to reduce the risk in our patients. We can see that lovely gentleman who says everything's fine on the phone, but we can say, well, it looks to me that, and different clinical symptoms. So we did the second trial, and then we found again that the data showed us that this was actually a very quick way to access our patients in care and nursing homes. Yeah. And we proved a 3-fold increase in productivity.
Absolutely.
Now, we know that our profession is a small profession, but it's very important to maintain the health of our citizens. So we found that we can, instead of seeing 6 patients, instead of having to travel, getting in our cars, listening to Classic FM and doing
do the home visits.
Yes. We can actually link up and we can increase our productivity 3-fold. And that's because we don't have to do the travelling and we don't actually have to do the setup of the patients when we're in the care home.
No, so the nurses are trained, aren't they? The nurses are trained to get the patient sat up, get them in the right position, to get the utensils ready, to get the different food consistencies ready, to make sure the person's alert. It might be they've had a bad night the night before, so they could just ring and cancel and you can reschedule for the next day. So when the nurse is doing all of that work, it means that you're not doing it, and they then ring in when they're ready to go. So we can actually focus on our core skills, which is assessing the swallow, rather than actually doing things like putting them in the right position, because they're already ready for us.
Yes.
Yeah.
And little did we know, because this was in the days before the NHS long-term plan. So, you know, referring to that I think that came out last year, the year before, and it says that healthcare professionals need to really seriously have a look at the digital world to see if, and actually the quote is, digital first, leading to richer and longer face-to-face interventions. So we were a bit ahead of the curve in doing that. And
which causes its own problems.
Well, it does, because some people aren't ready for change.
No.
But it's okay, we've got a thick skin.
It's a good job.
That's right. And also we had a really good purpose, because it was all about the patient, centred on the health of the patient. But since we developed teleswallowing, the world has changed.
Yeah.
We are getting more digitally savvy. And going back to the long-term plan, I think that's focused healthcare people's minds, that we really seriously have to consider looking at technology. So we were very lucky, I think, that we've been mentioned in a few government reports.
I think so.
It's
nice to get the recognition, isn't it? When you've put in so many years of hard work, to get the recognition that actually this is a viable approach to healthcare.
Yeah, I'm very proud of that, about that. And, you know, we didn't know at that time that we were actually, there's something now called the digitally enabled workforce. Now, back then, you were lucky if you had, I mean, we're only talking 5 or 6 years. But back then you didn't have laptops and you just went on the wards or went down to visit. But what we're doing now is making a really valuable contribution to the overall NHS plan about building a digital ready workforce. And okay, I've come out of clinical practice now to really work on that, because my career has now evolved that yes, I was clinical professional, but then because of the teleswallowing, my NHS department wanted me to go into health informatics. Now that's really big, it's really different for an allied health professional to do that. And my job now is to build digital practitioners prescribing digital tools. And that's based on the work that we did, you know, Liz. And we've made that contribution. But you know,
I think that's really valuable, because once you've got that digital tool in, and the people that actually did the teleswallowing, and the people who got familiar, and some people were quite fond of using.
Yes.
People that have been in the workforce a long time were quite fond of using an iPad and clicking on the button. That was something that was quite alien to them. So once they built up that confidence, they found that they could actually use that tool to link in with the dietitians, to link in with tissue viability, to link in with the GP, so they could get faster healthcare. They could get care at the point that it was needed, rather than actually waiting for it. They could also contact other healthcare professionals or real specialist colleagues, so that they could give them advice if they were stuck. So it has actually evolved into something else. It's grown, hasn't it?
Yes, yeah. And again, really proud about that, because we we sort of knew ahead of the curve, didn't we, that was going to be needed. And that really was based on the fact that we're a scarce resource, and we have to evolve. We have to be responsible about delivering different methods of healthcare ourselves. It's not going to be somebody else. It's our responsibility. And I was amused, actually. I was at a conference, a digital conference last week, and you know we have some situation at the moment with a possible epidemic or pandemic, and I'd alerted my NHS executives about the fact that they could use telehealth to protect staff, not having to go into situations.
Absolutely.
But also still to deliver really good quality healthcare. And I was amused because at that conference, the luminaries in NHS England were beginning to say, use telehealth. So I thought, it's come full circle. We knew this.
We knew it was going to happen.
Yes.
But I think it's really hard to come up with an idea, to work hard at finding the evidence for that idea, and then to have the resilience and the perseverance to keep going. We know there are areas in the country that are using telehealth, and we know that there are areas in the country that are using teleswallowing as well, and it's making a big impact on their caseloads, so people aren't having to wait weeks and months, and in a couple of places years.
Yes.
I shouldn't say that very loud, should I? Waiting years for an assessment of their swallow.
And you don't have to.
You can actually do it quite clearly at remotely. And I think the other nice thing is as well that we're not trying to replace people. If you still want to go and visit the patient, well then go and visit the patient.
Yes.
You've actually got more time because you've saved time by getting through the perhaps easier ones by using the remote tool.